Hello, everyone. Oh my gosh, Veronica, you always make my day. Yay for dancing. Oh my gosh, I was wiggling in my chair. Oh, it's so good to see all of you. Welcome, welcome. Oh my gosh, I was reviewing our training today and so excited to share this training with you. I hope you all had a beautiful weekend and just remembering to honor those in service yesterday, but really just wanted to welcome you and say hello to everyone. Looks like it's raining in North Carolina. We have someone, Julia from Minnesota, welcome. Douglas is from Manhattan, welcome. And Lisa's from Yorba Linda, California. That's a beautiful area. Amy's in Wisconsin. Diana, you're from Wisconsin as well. Have you guys connected? Amy and Diana, have you guys connected? I hope you have. Please do. I'm not sure exactly where you were at. So Amy Martin and Diana Keller, make sure that you guys connect if you're still in this, if you're in the same state. Gloria's in the Bay Area in California. Shannon, so no video, that's okay. That's okay. We're glad you're here. Myra's in North Carolina. Um, is it Etta or Ida's in Tennessee? Welcome. Ohio, Florida. Oahu, Oregon, Utah, Massachusetts, Florida. I think we're covering all the bases across the country. This is so exciting. I'm so glad that you guys are all here. Thank you so much for joining us. And gosh, can you believe we're already in week five of our training? Last week was incredible. How did it go? How did your homework go? I saw some people post in the Facebook group, which I just love seeing practicing with friends, families, and even some doula givers on how to have that conversation with your client and loved ones. Um, Something that I think for me personally, I needed all the practice that I could get having those difficult conversations, and so really want to encourage you guys if you haven't had a moment to practice having those conversations. Please just grab a friend, maybe your partner or a loved one, and really just allowing yourself to practice having those conversations. I promise it's not scary at all. I think the people that love you and they want to support you on this journey. So as do all of us. So if you want to practice with one of us, let us know. I am today again, okay, I say this every time, but this is really a good one. This training is specifically about, we're stepping into the level 2 training where we're going to talk more. We're going to do a little deeper dive into medications. And we have to remember that we are not going to be the ones administering the medication, but we are going to be helping provide some information and helping support our family, caregivers, and clients, how to navigate supporting them. When we have knowledge, I think that helps to create less fear. And really, you guys are going to be the experts in this area. The hospice nurses are going to be the ones ordering the medications. You are going to just help be that guide and supporting them. Um, you are always going to have hospice 24/7. But again, remembering that we are not administering the medications, we're just there to act as a guide. And Suzanne does an amazing job going over these medications. You guys are going to be the experts. So, and one of the things I wanted to share is that we're also going to be discussing the next few weeks about the top 10 disease processes for people at end of life. It's just a robust training. So I want you guys to just grab a cup of tea, make yourself cozy. We're going to go ahead and start the training. I just wanted to give a shout out to the people that are coming to the Friday happy hour and office hours. We did our first happy hour last Friday, and they let me practice how to do breakout rooms. They were so patient with me. So I'm always asking for your kindness and grace as I go ahead and set up the screen sharing so we can go ahead and start the sharing. We're gonna, I love that you guys are all in the chat telling each other where you're from, but we're gonna go ahead and quiet the chat and we're gonna go ahead and start the training. And then afterwards, be sure to put hashtag questions so that I can try and get to as many questions as possible. And then we're going to go ahead and use the raise hand. Um, um, Raise hand symbol, raise hand action to use that at the end as well. So without further, can you guys help remind me? Last week I forgot to do hearts, and I want to make sure and record. This is just a phenomenal group, and you guys are so full of energy, and I just want to be able to record you guys because during the graduation, it's always fun to just see the pictures and all the love that's being sent to one another. So can somebody please help me to remember to put hearts up at the end and we'll take little screenshots. Okay, Tina, I see you nodding your head. Veronica, Heather, help me remember. Okay, okay. This old girl needs all the help she can get. Okay, all right, you guys, I'm gonna go ahead and screen share. And thank you for your patience.
Hi, everyone, and welcome to Doula Giver Certified End of Life Doula Training. My name is Suzanne O'Brien. Congratulations, you are about to begin level 2. So I want to say congratulations on finishing level 1. The foundation and the way that the certification training is structured is like a brick house. And so that foundational training that you just did, the level 1, learning the 3 phases of end of life and the interventions that you would use within each of those phases, coupled with the 3 questions that you would ask on every case in every visit, is going to be your foundation to being an excellent end of life doula. And now we're going to go deep. We're going to go really deep into, and these are the pearls. I'm going to teach you, again, things that sometimes, took me 5 years to see one of them, or just, trial and error to where you had a condition and it went really well by what you put into place. I'm going to give you all of that knowledge in level 2. So you might be saying to yourself, okay, if this is a non-medical profession, which end-of-life doulas are, why am I going to be learning the top 10 end-of-life diseases? And why am I going to be learning the common medications used in end-of-life? Because, this course has been created and designed just as if, as the hospice nurse, I was teaching the family how to care for their loved one who was dying. And that is the model of hospice, and people don't really understand that. They don't fully understand what hospice does because we just don't talk about death. We're not having the conversation that it's an inevitable natural part of our life's journey, and what support system is there, and what do things mean, and what can we do what choices do I have? So when it shows up, we're all kind of scrambling, and people know that hospice means end of life for the most part if they know that, but they don't understand what the services are, what the services aren't, how much time a hospice nurse is actually working with the patient and the family. And these are all things that are critically important. So as the hospice nurse, I'm going to teach my family how to do the care. And that's the model of hospice. So I am the medical manager. I come and I assess the patient and I teach the family how to do that care. Remember, the person's at home. Most people want to be at home. Most hospice is done at home. And 24/7, the family is the caregiver. And the people come in as hospice nurses and they have aides, and it's wonderful, a social worker. But the real model is that we're teaching the family who's there. Even if I have an hour visit, then the family's there for the 23 hours that I'm not there. And so we're teaching them how to do the care. And that's going to very much be taught the way that the disease process earlier on in the journey is affecting the presentation and the comfort of that patient. Beautiful thing is that we know that this disease, and this is an end of life situation, we know that it's not going to get better. We know that it's going to progress, so we can count on things progressing. At what rate, we don't know for sure. And again, the goal is to have optimal comfort each and every day with that patient and that situation. So that's why we ask all those 3 questions on every case in every visit. So what I will share with you is a few tips to doing level 2 in the beginning. Go slow. Do this a few times. It's very interesting. I always am continuing to try and grow and learn things. Not so much, I'm always open to it, but more in the bigger, you know, marketing and internet kind of, just improving all of the business and online and all of that wonderful stuff that we're reaching people all over the world with. But it's interesting because it does take a few times sometimes to learn to hear something and to catch it all. So for those of you who have no medical background, and most of you do not, that's okay. In fact, it's I want it that way. I really do. I want you to be able to, with a clean slate, just build your doula house and become that great doula. So we are going to talk about medical terminology. We're going to be sharing information. And I don't want you to feel that you're not catching every nuance of it. I want you to know that, first of all, you have your classroom open to you forever. But you have the live webinar that you come on where you can ask questions, and then you can go and review this. And so I will share with you that I think it's great to do it more than once. The other thing that's really great to remember is that you're not expected to remember all of this. You're not expected to memorize this, but I want you to know that it's there for you. So in the future, in 5 years from now, if you have a pancreatic cancer patient, I want you to be able to go back to your level 2 pancreatic cancer section and see right then and there, what are the symptoms? What are the interventions we're going to offer as a doula? What are you going to be looking for? So you don't have to memorize it, but know it's there for you. And it's really empowering. This is really the richness, the juice on top of all of the training. You're going to get 10 years of bedside experiences brought into these case studies, brought into these disease processes and how to manage them. So let's begin. So this is level 2, week 1, certified end-of-life doula training by Doula Givers. I'm super excited about level 2 for you. So welcome level 2, end-of-life doula training. What you will learn in level 2, you will learn the common medications used in end-of-life care. You will learn the top 10 end-of-life disease processes. And you will also get an end-of-life doula manual at the end of week 4. And that is something that you can print out and keep in your car or have at your, bedside, whatever you'd like. It's something that you can print out. It's the entire levels 1 and 2. It even has part of 3 in there, so you have it all at your fingertips. You don't have to worry about going back into your modules if you are somewhere and you want to look up something quickly. All right, so let's start with the common medications used in end-of-life care. Okay, the first one is liquid morphine. It's known as Roxanol. So you probably are aware that medications always get 2 names. They get a public name, and then they have a name that's, attached to, the industry kind of name for it. So Roxanol is liquid morphine. Now, let's just get this right out on the table. Morphine, that word is very scary to many people. We know that morphine technically is a very strong narcotic medication. However, in very low dosages, it's not harmful and really strong. And we have to really, really be honest and remember the fear of medication can prevent us from using medication that can greatly help somebody's situation and comfort level. So the medications are one of the main things that I find that families are really having a hard time with and petrified about, don't understand, don't want to use the medication wrong and, give too much. And you can totally understand that. However, we have to make sure that that family member is comfortable, whoever's going to be administering it is comfortable with the medication way that you do it, the dosaging, the everything about the medicine, handling it, how you draw it up, because again, these are in liquid form. And the reason that these are in liquid form is that What did we talk about in the telltale of the transition phase? That there's inevitably going to be a day that that patient will not be able to swallow. And that is exactly why you have these liquid medications, because you still will need medication if you have a lot of pain or breathing issues, or even anxiety. But if you can't swallow and you only have pills, what do we do then? So this is really, again, what you can anticipate. And when my rule of thumb, when I was a hospice nurse, when somebody was coming on and coming home on hospice care from a hospital, from, whatever they were going through, that they got their terminal diagnosis and they coming home on hospice, my rule of thumb was that within 24 hours, I wanted liquid morphine and liquid Ativan in that home, in the fridge. They put it in the fridge so that people can find it. We'll talk about that later. But why would I want, if that patient has no history of pain, no history of anxiety, no history of breathing problems, why would I be so adamant as a hospice nurse that I'd want those medications delivered and in the refrigerator within 24 hours of them coming home? Because we know that we have an end-of-life progression, and chances are is that you are going to run into pain, breathing issues, anxiety, or all three. It always happens at 2 o'clock in the morning. And if you do not, these are very difficult medications to get, by the way, too. So they're triplicate prescriptions. Not every pharmacy will carry them by any means. So they have to come from specific places. And they're very hard to get. So if you have somebody who is going through a crisis of pain in the middle of the night, cannot swallow, and you don't have that medicine, it's going to seem like an eternity for everyone. So we want to, especially, and breathing issues. So especially you want to have those in the house. Now, I'm speaking at this moment as that hospice nurse that wanted them there. But if I was a doula, that is the same thing that I would want. I would just make sure that I delegate that information and request to make sure the hospice nurse is on top of that and it's coming. In a very nice, respectful way, just that we're all on board and on the same page. Now, people sometimes will automatically be issued these medications when they come on hospice, or if they've had a history of pain and things of that nature, breathing issues, they probably have some of this medication already, but you have to find out. And I would never just say, well, let's just wait and see. Absolutely not. So let's talk about the liquid morphine. At the end of life, liquid morphine is your best friend. Okay, I just want you to remember that. At the end of life, liquid morphine is your best friend. Why? Because it is one of the most effective medications for breathing issues. And a little tiny bit of morphine can help open up the airways of the lungs and help to even out breathing. And what we're going to talk about tonight are breathing issues at the end of life and breathing diseases. Breathing issues are the most complicated end of life processes that there are, things that involved airway. Okay, so we have to be on top of this. I mean, think about somebody who you can't get a breath in. You're having an end of life process, and on top of that, now you're struggling to get a breath in. So it just is, there's no excuse for it not being tightly managed and being on top of it. And we're really going to talk about all of the ways to manage that tonight, because like I said, I talk about the top breathing issues first in the first class, because these are really some of the most important things that you could possibly know. And I just want to make sure that we hit that right at the beginning, make it really clear, answer all your questions, because there's no room for error here. We don't have time to go backwards. The beautiful thing is we know what can unfold at end of life. So we're ahead in that sense. So I want to talk to you about the liquid Roxanol. It is delivered in a 30 ml bottle. That's milliliter. ML stands for milliliter. And the dosage is it's 20 milligrams to 1 ml. Now, you will never give a medication as an end-of-life doula. That is not what we do. We don't even give over-the-counter medications. I want to keep the lines very clean for your practice. However, you do have to know what medications are being used at end of life. You do have to evaluate the level of knowledge and being comfortable of your caregiver, because they are the ones that are giving it. So if somebody has no idea what you're talking about the comfort kit with medications, about the liquid morphine, if they have no idea what you're talking about, we're in trouble. So I really feel that the medications need to be taught and retaught several times. I take an opportunity every time that hospice nurse is there to go ahead and quickly just make sure that, watch the caregiver draw it up and see what the dosaging is, and make sure there's no bubbles in the tube. And if there's any questions, because I want people to actually go through the motions of drawing it up and handling it, because that helps to ease the stress of it. So liquid morphine, it's for pain, but it's also one of the best medications for breathing issues, which do come up at the end of life and with certain disease processes. 20 milligrams per ml. So a low dose would be 0.25 ml, which would be 5 milligrams. So we always do a little dose of anything, any kind of medication that anyone is going to go on, especially pain medication. You start with a small amount. You don't know how their body's going to react. You don't know, if a small amount is going to be great. You can't take medication out of somebody's body. You can put more in. So I am always extremely cautious with medications, but these, especially for breathing issues, are used in very, very small dosages. So that's the liquid morphine, also known as Roxanol. The other one is liquid Ativan, and it's also known as lorazepam. The dosaging on that is 2 milligrams per ml. So what you need to be careful of here is that they both come in 30 ml bottles. Certain pharmacies certain pharmacies may have a different color of the liquid. Sometimes lorazepam could be in a green, but I've had many that have been the same clear liquid. And so, can you see if your family is really stressed out and scared and kind of, just not present and trying to do the medications, how these could get mixed up possibly. So you want to be super clear. I would even label it. I'd put it like another indicator on it. Here's another thing that you need to know. So hospice has what you call a comfort kit, and that has a bunch of different medications, including the liquid morphine and Ativan, suppositories for Tylenol, nausea medicines, anxiety medicines, so things that can be pulled from if need be. And they actually have them with colored dots on them. So they come to the home with colored dots on the bags that are pills, and even, something else will have a colored dot on it. So why do you think that there are colored dots on the medications in the comfort kit? I mean, alongside of all the regular verbiage. Because people are so checked out and scared that if somebody's trying to guide them over the phone, they say, go get the packet with the purple dot on it. I mean, this is how incredibly scary and checked out and removed people are at end of life, that they had to color coordinate it with a dot so that they could literally, like almost being in kindergarten, say, go get the pack with the red dot. And so that just shows you like what we're up against and the intensity of it. So the liquid morphine is used for pain and or breathing. The liquid Ativan, lorazepam, is used for anxiety. And the ABHR, that is a nausea medication. I picked out these three because if you give me one thing at end of life that I could use, if I could only pick one medication, you're giving me the liquid morphine. If I needed, and nausea is a big one too, because nausea really does present in a lot of people's experience, especially if they've been going through chemo, things of that nature, and nausea can literally just ruin somebody's life. So what you have here is the RDT is a rapid dissolving tablet. And this is a pill, but you put it with a little water under somebody's tongue and it dissolves. They don't need to be able to swallow to take it. The ABHR, those are all standing for, it's a combination. It's called a compound. And so nausea goes 3 different ways to the brain, 3 different pathways it travels to the brain to say I'm nauseous. What happens is there are medications that cover one pathway. So at end of life, if you're nauseous, and I've had this all of the time, I say to my clients, I'll say, are you having any nausea? And they said, yeah, but I just took my nausea medicine, or. And so to me, I'm saying that, well, that's not working then. So that's not the medication that's covering the right pathway. So what they did was they came with a compound, which is wonderful, so that that pill will cover all the pathways. And so it will take care of that nausea, and your clients will absolutely love you taking away their nausea. We're going to talk about the top 10 end-of-life disease processes in level 2. We're going to start with a couple tonight. So, like I said, I'm going to start with some of the most difficult end-of-life disease processes so we really can flush them out, talk about them, and absorb what we need to know. So, we have COPD and emphysema. COPD stands for chronic obstructive pulmonary disorder, and there are two types, the chronic bronchitis and the emphysema, and then you also have just an emphysema diagnosis. And these two are a little bit different, so I want to explain what they are. So when you have COPD, you have an obstruction, you have an inflammatory process, okay? So you have things that are swollen, inflamed, blocking the airway. So I love biology, and I love the human body is just so interesting and just magnificent in its making. But if you think about these lungs, these porous, pink little lung tissues that, take in oxygen to oxygenate your whole body with your breath and give off carbon dioxide, and that subtle exchange, that breathing in and out, and that exchange is what keeps us alive. So, I mean, it's just, if anything happened to those little lungs, well, it's really difficult. So with that being said, that the chronic obstructive pulmonary disorder is a blockage. So it's an inflammation. It's preventing that exchange of oxygen and carbon dioxide the way that we as healthy beings would have it. So there's a percentage that you're getting. The emphysema is a destruction of the lung tissue. So there are little tweaks and things that we can do with different disease processes to help make them better. Yes, yes. So with COPD, there are inhalers, steroids, there are, again, the liquid morphine to help open up the airways. With the emphysema, unfortunately, there's a destruction of the lung tissue. So no matter what you try and do, you can't get more air in there because the lung tissue is dead and destroyed. So really intense, and we, especially as an end stage hospice terminal diagnosis, so we have to know what we can do to help these people in this process. The symptoms that you will see with COPD emphysema. Okay, so when you get your client, you're going to, when we get to level 3, we're going to go over all of the business materials, your interviews, and there is an intake assessment form that you're going to have. And so one of the main things is finding out what the disease process is. And is your patient on hospice care, and all these really great things that are on your template. So you have that at the ready. But you will probably find this out before you even go to see your patient. They might say, okay, we have a woman, she's 75 years old, she's going home today with hospice, and she has end-stage emphysema. And this is really important because you want to start thinking as a doula before you even walk in that house. You want to start thinking, what do I need to know to help this woman? And I often start to paint a picture in my mind of, if somebody has end-stage emphysema, what does that look like? And what are their symptoms going to present like? And what do I need to make sure is in place from hospice and from the doula side of things? So let's talk about that. What are you going to see symptom-wise with a patient with COPD and emphysema? That SOB stands for shortness of breath. And when I say shortness of breath, I mean shortness of breath just having a conversation. I mean shortness of breath eating, shortness of breath taking a step and pivot to a commode, because this is end stage. So tight symptom management is critical with this disease process. We have to be on top of it. We have to have great protocol and exercises and drills for the family, which we'll talk all about tonight. So shortness of breath. I want you to think in terms of that you have a tank that's 100%, okay, of oxygen. People that have COPD and emphysema might have a tank of 20, and that has to get them through the whole day. And so you're going to have to really be careful about what you pick and choose for using that 20%. And really it's up to them. However, there are things that are activities of daily living that we have to do. We have to go to the restroom. We have to, get changed or washed up. We have to eat something. So right there, you might have used up 15%. And these things are things that we have to do. So we want to be really careful how we work with this. Shortness of breath. Number 2 is anxiety. I want you to start to think that the minute that you know that you have a breathing issue with your client, whether it is coming on services with a breathing issue, meaning COPD, emphysema, congestive heart failure, you're going to see it with that. ALS is going to lead you to a breathing issue. Congestive heart failure will lead you to a breathing issue. Liver disease at the end will lead you to a breathing issue. Lung cancer, depending on the cancer, may or may not have breathing issues. So I want you to immediately think that if you have a breathing issue attached to this person and end of life, you will have high anxiety. Think about it. If you can't get air in, there's probably nothing worse than that. And once somebody's getting anxious, they can't get the air in, the anxiety goes up, which even prevents more air from getting in. So it's a very important disease process to manage and keep calm and have it tightly symptom managed really tightly, and also keeping the atmosphere as relaxed as possible. You'll see increased respiratory rate, heart rate, because people are going to, the body's trying to get more air in. So it's like trying, get, pumping to get more air in, but it's just not going to work. So we want to be really careful with that. And the shaking and trembling, and this is a latter stage presentation that you'll see with the retention of the carbon dioxide. So it's so important. It's so important to know what you're going to be seeing with these disease process even before you go in the home, so that you're not caught off guard. And also there's probably going to be not just high anxiety for the patient, but for all of the family when you walk in as well. So interventions for the COPD emphysema patient. There's medications. What medication is your best friend at the end of life? Liquid morphine. Okay, so let me tell you this right now. There are patients that come on end of life, terminal diagnosis, hospice care for COPD, emphysema, and they have been traveling down that pathway with that disease for years. And they have been using inhalers. You probably even know some people that have done that. And their inhaler, they have like a rescue inhaler, and they have like an inhaler that they use, every 6 hours or something of that nature. I have to let you know, do not ever take away those inhalers, even at the end that they're not working, because now you're going to have the medications that are really needed. You're at end stage. People are so dependent on that inhaler because of the fear, because they can't breathe, because they've used it to rescue when they've gotten tight, that it's like a pacifier. So the thing you have to remember is that they're probably not doing any good at all, but they always want to know, where are those inhalers? They need to be right next to where I can reach them, right next to my bed. So just psychologically let them have it, but know there has to be a whole other care plan in place, and hospice knows that and does it. But people would say, well, we're not using inhalers, let's take them away. And the patient will just freak out because it's more of a mental thing. So just please be aware of that. So your medications for shortness of breath and breathing issues, your best friend is liquid morphine. What are you going to see that goes right along with breathing issues at the COPD and emphysema patient, or anyone who has breathing issues. You're going to see anxiety. So your medication for anxiety is liquid Ativan, and Ativan is a cousin, I call them cousins, of morphine. So they have a synergistic effect. You would never ever see or want anyone to give medications together. Why? Why would somebody not give a dose of, if it was really, crazy and somebody couldn't breathe and they had all this anxiety, why wouldn't they give a dose of the morphine and a dose of the Ativan at the same time? Because you can't then evaluate what the effect is of which medicine, to make sure that your care plan is really tight. So if you give small dose of morphine, and then the patient breathing a little bit better, but not quite, then there's always a second dose ordered. And that usually does have a calming effect. They start to calm down, so you don't even really need the Ativan, but just know that you're going to have high levels of anxiety with breathing issues, and I want you to know that that Ativan, if need be, can be a secondary medication at some point in that. And this is just for your knowledge. You're not going to give any medications as an end-of-life doula, but families need to know this. Super, super important. Pacing activities. Absolutely one of the best things that you can put into place as an end-of-life doula. You want to have everything within reach for that patient. You want them to be as independent as possible within they're pretty much bed bound because they can't really do much. And so you want to have, when I say use of equipment, bedside tables, bedside commode. I love to have a baby monitor. I love to have a way that a phone that they can use, a trash can right next to the bed. So that, and tissues, anything that they want. I'm just thinking of a few of my absolutely sweet patients. Some have these great bedside tables with, candies on it and like a little stack of books and their tissues. And you want people to be as independent as possible. So you want them to have things in reach, the remote control for the TV, music, whatever they can have within reach. A little garbage and tissues is really important because people sometimes have a lot of junk coming up with their lungs. And so it's a very easy way for them to just, quietly cough and get that into a tissue and just put it into a garbage. They don't have to ask anyone to take it. They just it makes it not a big deal. So remember number 4, when we talked about energy for eating, soft, frequent meals, you want that to be a staple. You don't want people to be using and they don't either, using all their energy to eat. So soft custard, consistency, yogurt, you can even ground up things that somebody likes and just make them of a softer consistency. And again, small meals. I think a lot of people, they don't know what to do to help somebody at end of life. So they, sometimes bring in these huge amounts of food that maybe somebody liked prior, but then they feel bad that they're not eating it all. So just really be mindful. And this is just a great rule of thumb for all your clients is soft, frequent meals, especially at the end, and I'll offer, but you don't make them feel bad if they don't want it. So here's a technique that's excellent, is asking yes or no questions. So when people are on hospice and they're in their stabilization phase and they're in the bed and they can't walk anymore, but one of the things they can do is be engaged in part of the conversation. Remember when I shared with you my ALS man? He was absolutely just brilliant and wonderful, and he was completely paralyzed. He couldn't even use his arms, and he would just light up talking to me and educating me on lots of different things with the nervous system. So that's what people can do earlier in their process. Not really COPD and emphysema. We always want to be mindful that they have airway restriction, and especially if they are talking too much, they can get into that. So we want them to be part of everything. We don't want to not be talking with them. However, this is where you do most of the talking, that you kind of go on your little sharing information, and they can shake head or do yes or no answers to questions that you ask, instead of using the technique that we do in stabilization phase, where you're asking open-ended questions This is where you're asking and letting it be part of just a yes or no conversation. And you're going to teach your families about that too. It preserves their airway. I will share with you that people can go into a breathing spasm. And so we want to avoid that. What would bring that on? Remember, they have 20%. Maybe they've done a couple of things, they're down to 10%. And it can get kicked off by doing too much exertion. So if you are trying to do a physical or walking too far or doing something, or even talking, I can start to bring on a lung spasm, and that's a crisis state. So where they can't get air in. So we're going to talk about how to handle that, but prevention, prevention, prevention is the best answer. So what I'm going to teach you, how we're going to do this drill, we're going to set up a drill, is going to prevent this from being a 911 call. Oh, it's just stressful thinking about, because it's so involved. And I had a woman who had end stage emphysema, and her husband kept dialing 911, and she said to me, no matter what happens, she said, I don't care if I can't breathe at all. Do not send me back to the hospital. Just heartbreaking. Number 6, teach pursed lip breathing. So this is where you would instruct your patient to breathe like they are sipping through a straw. So you have your lips are together where you have a little circle, and you breathe in nice and slow. Just breathe in. That allows the most oxygen to get in to your lungs. So that's called pursed lip breathing. We're going to open up the diaphragm by using a positioning. So what we're going to do is imagine that you have an over the bed tray table, and you have your patient sitting at the side of their hospital bed. You have the table in front of them. You're going to imagine their arms crossed and leaning. The arms are on the table. So their back is in very bad posture, but it's in a great C shape that allows open diaphragm breathing. So that automatically allows the diaphragm to expand to its maximum position. So we're going to be using that. Now these, what I'm teaching you, are for when people are getting short of breath, or when people are struggling to get air, like it's going towards that crisis. These are the things we're going to implement. Pacing activities and doing all these things is a must for the care plan. But when we do open position breathing, we're going to talk about things to help when they're having a little bit more trouble. So number 8, an acute episode drill. This is really important because your client, if you have tight symptom management and you have great education, you can see somebody starting to go into an acute episode where they can't breathe. And the minute, I have to tell you, the minute that they start to feel that they can't breathe, it kicks it up even more, because the anxiety goes up so much more. So it's like, what came first? It's just really hard to try and calm it all down, but you can. And you can do it within minutes. And if somebody calls 911, and I'm not saying that you can't do that, but here's what happens. It sets off this whole array of things, and at the end of the day, and it causes a whole bunch of stuff, and the patient is, all these people come, and the patient's put on the stretcher, and they are put in the ambulance, and they go to the emergency room, only to get stabilized the way that you have now taught this family in a drill, or made sure that they know, within minutes. So 6 hours, and that's why that woman said, no matter what happens, do not send me back to the hospital, because it was terrible. And they just stabilized her the way that you have everything in that house and techniques that you can be able to teach the family how to do that within minutes. The key is to not get into the crisis, not get into the acute episode. I have patients that I see that I'm talking with, getting to know them on the first or second visit, and I can see them trying to say, more words, and really trying to be polite, and I can see them starting to go into a spasm. And I said, let's just stop. I just stop them right there with a lot of love and wait till it all simmers down. And then mental note to myself is to not create a situation where they're forced to answer a lot with words. So just make it more of a limited yes, no, or whatever we can do and still have a great conversation, but not that they're required to talk. Number 9, create a calm, controlled environment. Noises and chaos raise anxiety, and this is already an anxiety ridden disease process. So we want to have a really nice, calm, controlled environment. All right, let's do some case studies. We have a 76-year-old female with terminal diagnosis of emphysema. She has a husband, Bob, who's 78. They have been married for 51 years. The patient has 2 adult daughters who are in the home on your first visit. You immediately notice that the daughter's stress level in the house, you immediately notice that the stress level in the house is very high and the daughters seem nervous and anxious. You meet the patient who is in a back den lying in a hospital bed. You notice that she's shaking as she says hello to you. She's also wearing oxygen in her nose. As you look around the room, you notice that there are multiple inhalers on the table. The patient is having great difficulty with shortness of breath while she's trying to answer your questions. During your visit, you notice that her husband, Bob, has gone outside twice to have a cigarette. You find out that Bob has been diagnosed with lung cancer a few years ago. You also notice that there are several 8 to 10-year-old children playing in the yard. Okay. When answering this case, always start with the 3 questions. All right. So let's go to safety. And I'm going to go back to the slide so we can kind of go through them together. Are there any safety issues? So what have we decided and know that right off the bat is considered a safety issue? Age. So she's 76 years old and Bob, her husband, is 78. So right then we have a red flag that age is a safety issue for this couple. The patient has 2 adult daughters. Okay, they're in the home on the first visit. You notice that the stress level is very high. The daughters seem anxious. Okay, so that's not safety necessarily. You meet the patient who's in a back den lying in the hospital bed. You notice that she's shaking as she says hello to you. Is her shaking a safety issue? Yes or no? So it is, because if she's trembling and shaking due to her condition, that means that she might be very unstable on her feet. And of course, we know she has an end-of-life process, so she's probably very weak. Let's talk about the oxygen for a minute. Safety issue, wearing oxygen in her nose. When somebody has oxygen in the home and is using oxygen, is that a safety issue? Yes. So right off the bat, you have to say oxygen safety. So oxygen is a fire hazard. So and again, this is not your responsibility. Hospice is managing medically the care and responsible to do the teaching for all these things. However, you're responsible as the doula to make sure that everyone knows, make sure that things are taught and done correctly and remembered. So just so you're aware that there's supposed to be no open flames or no real heat source next to the oxygen tanker container, that oxygen is very flammable, so nobody should be lighting candles or smoking anywhere near the patient. We've come a long way with oxygen being a lot better, but it is still a fire hazard and there's supposed to be a sign on the front door that says oxygen in use. And that is a regulation that needs to be adhered to for hospice purposes and safety purposes. So just know that if somebody has oxygen, it's a safety issue. Why else may it be a safety issue? Because if people are on oxygen, they could trip over the tubing if they're at all moving around or ambulating, or even if somebody's helping somebody move, that oxygen tubing gets caught under people's feet very easily. So that should just be like, a flag up that you make sure that they understand no open flames, no smoking, and the safety of moving around really carefully, making sure it's not under somebody's legs. Okay, any other safety issues here? We notice inhalers on the bed. The patient's having great difficulty with shortness of breath while she's trying to answer your questions. So no safety there. During the visit, you notice that her husband, Bob, has gone outside twice to have a cigarette. Safety issue? Okay, well, he's outside. However, the cigarette is a safety issue with the oxygen, and you're there for the visit and he's gone outside, are we 100% sure that he's always going outside um, to have his cigarettes? We're not there all the time. So we want to make sure that that's really understood with the family. You find out that Bob has been diagnosed with lung cancer a few years ago. You notice that there are several. Okay, so no more safety issues here. Let's go back and let's do acute. All right, so we know that the age is safety. I would, again, on an emotional level, the 51 years being married, somebody's losing half of themselves. It's just, even if it hasn't been the best relationship, there's going to be this absence of that's going to have an emotional component to it. And so you just want to be aware of that as an acute issue. The patient has 2 adult daughters who are in the home on your first visit. You notice that the stress level in the house is very high. Is that an acute issue? Yeah. So one of the things we want to do quickly is get everything stable. And so a big part of that is getting that stress level down. The daughters seem nervous and anxious. So gosh, yes. So these daughters are really the main caregivers. Bob, going out twice and having a cigarette and having his own issues that he had lung cancer and now his wife has terminal emphysema. It seems like he's kind of checked out. And plus, I would never want to put the whole soul caregiving on a 78-year-old partner, husband, wife, or anyone. But these 2 daughters are really the main caregivers here. And you notice that their stress level, they're nervous and anxious. So that's an acute issue. I'm going to want to help right away. The patient's in the back den lying in the hospital bed. We notice that the shaking, we call that a safety issue, which it is. The oxygen has been deemed a safety issue as well. You look around and notice that there are multiple inhalers on the table. Okay, so here's that inhaler piece. So really important to understand that these inhalers have been a saving grace for people for years, usually for years. And when they did have shortness of breath, the rescue inhalers do work. And so they're so attached to them. They make sure that they stay where they are, but know that those are not really doing much. You look around the room and see that the inhalers on the table, you want to make sure that they are kept within reach of that person. The patient is having great difficulty with shortness of breath while she's trying to answer your questions. Acute issue? For certain. So if somebody is having shortness of breath while having a conversation, they're having shortness of breath with just about anything that they do, including at rest, which means that they will have shortness of breath just lying in bed. Sometimes you can hear that breathing, and, we just have to do everything that we can possibly put in place for comfort, for safety, for the ease of the breathing, because it's such a scary process. Okay, so Bob going outside twice to have a cigarette, acute issue. Noted. Yeah, I mean, we called it a safety issue because of that, but I also am going to call it an acute issue because I feel like Bob is really checked out. This woman has emphysema. We are not privileged to know the history, of this, but what happens if the emphysema could have, or he thinks, or may have, or, been part of because of Bob smoking? Other people can get lung issues. So maybe, does he have any guilt on that? I mean, there's no judgment here, but there's no judgment in anything we do. What we're just trying to really share is that seems that this person is not present and kind of checked out with what's happening, and he's smoking and he has his own lung cancer. So he's definitely not going to be our go-to as things start to decline. We're going to be caring for him. We're going to be trying to support him. I would definitely be getting a social worker in, working with him, because he's showing all signs of not handling this at all well. So that is an acute issue for me in that sense, that I want to support Bob in where he is in this process. You also notice that there are 8 to 10-year-old children playing in the yard, so that's not an acute issue. All right, let's talk about support system. We have Bob, but because of all the things that we've seen about it, I don't think Bob is our guy. I don't think he's going to be a really rock solid support as a caregiver. I think he has a lot of things to work through that will probably be putting that on more than anything else for him. We have 2 adult daughters. That's excellent. However, we want to really make sure that we can get their stress level down so they can understand the teaching, and just we can support them in this journey. Is it a shock to us that the daughters are nervous and anxious with an end stage emphysema disease process? Absolutely not. This is scary. I'm sure they've been through so much before they've gotten to this point. And now, if somebody tells you it's going to get worse, I mean, how scary is that? So we really want to build the trust. Remember your very first lesson, building the trust with these wonderful daughters and sharing the information that's going to help with comfort and make sure we don't head into a 911 crisis and all that we're going to implement. So those are the support system there. Any support system on here? No, we don't see anything here. Any support system here? Okay, so again, we do have Bob, but because of the things that I've seen on here, Bob is more of one of our patients rather than our caregiver. He's already checked out and he's got his own issues, so I'm going to try and see what we can do to help him move through some of the phases, especially because his wife is at end of life. So if he's not doing well now, as this starts to decline more and she starts to go into her process of transitioning, he could really have a meltdown and a hard time. So really want to try and get some support of him. But we have several 8 to 10-year-old children playing in the yard. 8 to 10 is a great age. In fact, it's one of the ages that they really want to help out. And there's things that they can do. They can sit with grandma, they can read to her, they can get her iced tea or, whatever it is. So there are lots of ways that they can be, and they should be brought in as part of this within reason, within their age appropriate. And also, you're not going to have an 8 to 10-year-old sitting at the bedside 12 hours. You're going to have little shifts. Let's have everyone take short amount of time. It's fun for everybody that way. Okay, so we answered the 3 questions for that case study. So we said, are there any safety issues identified? Are there any acute issues identified? And what support system was there? So additional questions specific to the diagnosis of end-stage emphysema. What is the main complaint of the emphysema patient? So this is what I want you to think. I want you to know before you even go and step foot in that house. If somebody says you have an end-stage emphysema patient, I want you to already be like, okay. And if you don't remember them, I want you to go back to that section it will be this section, level 2, class number 1, for the emphysema patient, what I can expect to see and what interventions are used for comfort. So the main complaint with the emphysema COPD patient is shortness of breath. What medication is best for shortness of breath? Liquid what? Morphine, also known as Roxanol. Patients with breathing difficulty often have high levels of what? Anxiety walks hand in hand. What medication is best for anxiety? The Ativan. So please also, very important to know that those 2 medications come in liquid form. They're called sublingual, so that people can take them under the tongue, in the cheek of the mouth. People don't need to be able to swallow to take them. They also can be given when somebody's in a sleeping coma. There are times that people will still require some medication. Maybe they're moaning, maybe they're breathing hard in their sleep state, and that liquid morphine can be given under the tongue or in the cheek pocket. Wonderful. That's why it really needs to be there. So non-invasive interventions to suggest for comfort for the emphysema patient are pacing activities. Remember, you've got 20% in the tank for the day. How do you want to preserve that? How do you want to spend that 20%? And this is, again, there are activities of daily living that we have to do, but instead of having my patient walk all the way down to the bathroom that's at the end of the hallway, taking 10% of her reserve, get a bedside commode. Have something really simple so that she uses 1% of that and has more for whatever she wants to do. If she wants to watch a soap and eat her tuna fish sandwich, or if she wants to have a little visit with her grandchildren, or whatever it is, just feeling better. So pacing activities, critically important for any airway disease processes. Offer small, soft, textured meals. Those are the easiest to get down. Chewing requires energy. You don't want it to all be used on a meal. And people can get short of breath when eating, so be mindful of watching your patient with that as well. Ask yes or no questions. Use that technique. Teach that. Teach all of this to your family. Make use of equipment. You have bedside commodes, over the bed tray table. Have everything in reach for that patient so that she or he doesn't feel that they have to be moving around trying to get stuff, that you have everything. Make it really as nice as possible. I've seen some beautiful tray tables with, flowers on them and little plants on it, and little candies on it and little notepads. I mean, really just whatever the patient wants. And isn't that great to be able to do that? Create a calm, controlled environment. Teach breathing and position techniques. The pursed lip breathing, which is breathing through a straw, allows for the most oxygen to go into the body, into the lungs, and positioning with opening that diaphragm. So it's bad for, you and I, it's bad posture in that. But for people, and sometimes they do it automatically, their body goes into like a C shape. But the easiest way to describe this is that your patient is sitting on the end of the bed. You have the tray table in front of them, and they're leaning over the tray table with their arms folded on that tray table, making a nice open C shape with their abdomen, allowing for their diaphragm to open the most of it possibly can. All right, so we're going to do another case study. But before I do that, I'd like to talk about a drill. So you're going to have what we call a 911 drill prevention. So you want to have your families all understand the sensitivity of all of those interventions and nuances to this case, pacing activities, having the patient answer yes or no to questions, small frequent meals, having everything within reach, understanding, and this is critical, that the caregiver has got to understand fluidly the way that the morphine is administered. Because this is going to be in a panic, in a crisis mode. So I always have them with the hospice nurse open it up and draw it up and say what they would do so that the hospice nurse can evaluate and make any corrections that need be. And I have it done several times until they are fluidly comfortable with it. Because when someone you can't breathe and you're not thinking straight, boy, you want to make sure that you have this down pat. So you want to have a drill with your family in place. You want to say, if mom starts to go into that spasm, which you can kind of tell, but you're just going to have a code. You're going to say to our mom, are you going into spasm? And she's just going to shake her head or raise one finger. You do not want to require her to talk more as this is happening. You can kind of tell. You've probably been there already. You say, Mom, are you having a spasm? And she says yes, her fingers raised, and the drill is off and running. And so you have that person who is the person in charge of getting the medication from the refrigerator and administering that. You have them. You have all the kids go outside if they've been running around in the house and it's too loud. You have another person with your mom asking her to assume the position and do the pursed lip breathing. This is all happening simultaneously. The medication's being administered. It's usually within 5 minutes. If you don't go back to homeostasis, to your baseline, there's another dosage of the 5 milligrams of morphine that's allowed to be administered. And usually between that 10 minutes, things are 5 to 10 minutes, calmed down and back to where you want them to be. So this is something you can do within 10 minutes, and this is something that sometimes will take 6 hours at the hospital with the ambulance and the whole thing. They will put oxygen on that person, a mask on them, but it's chaotic and it's a lot. And it's exhausting. That 20%, they've just been wiped out for days. So why go through all that when you want to prevent it from happening, and you can. All right, case study number 2. We have an 80-year-old patient with a terminal diagnosis of end-stage COPD. He lives alone in an apartment that is on the ground floor. You find out that he has recently been discharged from the hospital after falling twice. On your first visit with this man, you notice that he is having trouble balancing when he walks. He is holding on to the walls and furniture periodically. You also notice that he is getting the oxygen tubing that he wears continuously caught under his feet. Yikes. When talking with this man, you ask him what he had for breakfast. He tells you because you're doing your assessment. You're, getting to know somebody. You say, how are you doing eating? What did you have for breakfast? And he tells you that he made eggs and toast. You look around and you notice that the house is very cluttered and that there are no pans or dishes in the sink. You ask this man if he has any children, and he tells you that he has one son who is married and lives 30 minutes from him. He tells you that his son helps to bring him to doctor's appointments at times. When doing this case study, start with the 3 questions. What other additional information do we know about this process of COPD that will help us when caring for this man? Okay, so let's go back and see if there's any safety issues. So what's the first safety issue that you see jumping off that page at you? We have an 80-year-old patient. Safety. Okay. What's a second safety issue that's jumping off of that page? He lives alone. So right now, I would even be generous enough to say that even right now, if he's doing fine, we know that in the future, he's going to decline, and that's not going to be the case. However, he's not doing fine on our assessment. This has safety screaming out all over it. So first of all, we found out that he has been recently discharged from the hospital after falling twice. So a history of falls, he falls. What's going on there and why? On your first visit with this man, you notice that he's having trouble balancing books and he's holding onto the walls and furniture. This is not good, and he lives alone. He's getting the oxygen tubing caught under his feet. So this is safety screaming out all over it. So safety on this page, I don't see anything. Well, the house is cluttered, so that could be a safety issue too, but we have a lot of safety issues already. That's one of them. But I have real ones that are really even more prominent that need to be handled right away. But clutter obviously is not good. That can lead to falls as well. And those are our safety issues. So what acute issues do we have here? So most on this page, so mostly everything on this page is the safety, just one after the other. Let's see if we have any acute issues here. So he tells you that he made eggs and toast for breakfast, but when you look around the house, it doesn't seem that anything has been made in quite some time. Is he telling the truth or is he not telling the truth? I want to stress the fact that people don't always tell the truth because they don't want to cause more issues. They don't want to be a burden to people. They don't want to upset anybody. So they will tell these gentle, white little non-truths. These are big things. How long has this been going on? People deserve to have a meal. And if they can't do it I visit a woman who lives in my neighborhood, and she lives on the first floor, and she sits at the window. And I noticed for a long time when I moved here, a long time, a couple of months, that there was this woman, and she just continuously sat in this chair by the window. And I noticed that she had a walker next to her, and I noticed that there was never anyone in there with her. And I really wanted to, become friends with her. And then finally one day we did, she finally opened up and talked to me through the window. And she said to me, that she's very lonely. And so I said, well, I can bring you some leftovers. It's if I have them, would that be okay? And all of that stuff. And she was like, sure, that would be fine. And so it was very interesting because when I went there for quite some time before we got to another level, she would say, just put it in the kitchen, just put it on the counter there, and lo and behold, this woman could not set up a plate for herself for food. She waited for someone else to come in, and then to do that, she was embarrassed and she didn't want to burden. But gosh, we really have to be really diligent about looking to the truth of what's happening. People at an elder age are isolated, and nutrition is usually a factor that they are not having the meals the way that they need to. So we just want to be really mindful of that. So that's an acute issue. Let's see. So it's cluttered. Okay, so that we talked about that being safety. safety is always something we want to highlight. So I'm not going to call that an acute issue. I'm going to put that under the safety category. Anything else that's acute here? I don't see anything else that's acute. So I'm going to go to support system. On the first page, do we know of any support system? We don't really. So that's all safety issue that's there. And then the second page, okay. So we ask him if he has any children. He tells you that he has one son who is married and lives 30 minutes from him. That's perfect. And he also tells you that the son has been helping to bring him to doctor's appointments. Okay, great. So I'm thinking that is my support system. That's perfect. So this was an actual case. And when I called up the son to let him know that his dad was not safe at home and that he needed to be in a safe environment, whether, living with him or boy, he said, absolutely not. He cannot. He got a little bit fiery under his breath. He said, absolutely no way can he live with me. So again, there's no judgment here, but there's 50 years of history that you're not privileged to, and don't judge just because somebody is not willing to, we don't have the right to judge anyone, but it still remains that this person needs to be safe. So unfortunately, this person had to move to a nursing home, which most people do not want to have happen, but there was just no way around it. We didn't even have any buffer time. We were in a place where he was actively falling, actively not being able to balance and living by himself. Like, this had to be handled immediately. And so that was the only option that we had. Not ideal, but it happens. All right. What other additional information do we know about the process of COPD that will help us when caring for this man? So, what are your interventions in your hat for your doula work for COPD and emphysema? You want to have pacing of activities. You want to have small, frequent meals. You want to have use of equipment as much as you can. This man was walking down the hallway to go to the bathroom. And that was like, creating the fall risk again, but also exhausting him. And the tubing from the oxygen was getting all wrapped around him. So you have that, you have equipment, you have what is the medication that is your best friend with breathing issues, to see if that is something that he has on his medication regimen. And we would just be doing, now for a drill for him, it's really not going to be the case because he moved to a nursing home because he's living alone and we were not going to get a family in. But let's say his family did take him in, then we would be doing all of those exercises and drills with the family. I teach the patient the pursed lip breathing, and we include the patient in everything, because what you're trying to do is reassure this family that is so stressed and scared that there are answers, that it doesn't have to be always in this high anxiety that something awful is going to happen. And I explain to people what things do, what the morphine does, just that little bit. And then there's always a second dose if it's ordered for a crisis, but how we're going to prevent the crisis. And let's practice that. Let's practice mom raising her finger that yes, she's going into spasm. Let her practice sitting in the C-shaped position for the diaphragm breathing. Let her practice the pursed lip breathing. So we can really, again, not be as freaked out and new and running like chickens when something actually happens. So this is the same for COPD and for emphysema. Tight symptom management, controlled, calm environment, practicing the drills, putting everything within reach. Please remember they have 20% where you and I have 100 to get through their day. Activities of daily living, make as simple as possible with as least amount of exertion as possible, and then let them choose what they like, what activity they like, or what they like to do the other part, because they might only have one little section of their day that they're able to do something. What's important to them? Give them back the choices. All right, your homework for level 2, week 1 is I want you to take your journal and I want you to write down exactly how you would teach a family with an end-stage emphysema patient. Everything that you'd like to teach them about emphysema, about the yes, no answers, all of it, and give the rationale. Please go through all interventions to use for breathing issues and explain the rationale for each. There's something about the brain that if you just say, take this, don't do that, the brain doesn't really process and digest it and own it. But when you tell somebody the explanation and the rationale behind it, what the positioning does, opening up the diaphragm, what the pursed lip breathing does, allowing the most oxygen to get in, keeping carbon dioxide out, it helps to make it concrete. And we want to do that. Create a drill with the family and give each person a task and a responsibility. Some people are really a lot more comfortable with medication than others. That should be their task, their responsibility. You have a family of 6, so your patient is 75. Her son and daughter are the main caregivers. There's no husband. They have 3 children, ages 15, 9, and 5. So you're going to do a drill and explanation with this family with all of those people in it. Be specific. You have only a few minutes to calm the crisis down. So you can do this. Practice makes perfect. So going over it and letting them all ask you questions. Why does she go into spasm? What's happening? Her lung tissue is not taking in the oxygen, and it can get kicked into a spasm if it's overworking, and that allows her to not be able to get any air in. So we want to, and we can let them know, not only do we want to, but we can prevent that, hopefully, from happening when we're really good at our program that we're going to put together for grandma, which is going to be how we care for her every day, allowing her to have the most comfort. And then also, if there does become a time where it's a crisis or going into a spasm, we all know the roles that we're going to play in calming that down within 5 to 10 minutes. Very, very powerful. Okay, let's do the live Q&A section. Let's see. Do we educate and or suggest medications? Okay, so Natasha, you're not going to educate because I really want to take you out of any gray area as far as liability goes. I know it's so frustrating and annoying. However, that's okay. I'm going to make sure that the doulas are always protected and well cared for. However, what you want to do is have the family caregiver explain to you what they know and how they would use the medication and when. And if you notice that it's wrong, then you would say, we need to have the hospice nurse come back and reteach this. Okay, so I don't want you to do the teaching. I want you to evaluate the teaching. Suggesting medications, again, put it back into the hands of what did the hospice nurse teach you of what medication you would use for difficulty in breathing? And you would just know if that is right or wrong. And then again, if it's wrong, you have that hospice nurse come back and reteach until it's fully understood clearly, and that might take several times. Hi, I'm a retired respiratory therapist. Many of my patients smoked up until they absolutely couldn't anymore. Not a judgment or just an observation. Can I, as an end-of-life doula, recommend Nicoderm or another transdermal patch? It would help with the nicotine withdrawal. Sure, Elizabeth, thank you for that. And thank you for reiterating the no judgment. There's no judgment here. There's no judgment here. We're absolutely, always embracing everyone with no judgment. We do have to make observations sometimes for, again, making that good care plan. I have to tell you that I've had some patients that have, lung cancer or have a disease process, and they continue to smoke because that's what they want to do. So we have to make sure that that's a safety issue that's handled well, that there's no oxygen around, that they, go outside if they can for it. But yes, then you can say that when there's a time that that's not feasible anymore, that sure, Nicoderm or a transdermal patch would be a good answer. But those are medications, and those need to go through the doctor. So you can, say that might be a good option for them, but they have to make sure that it's cleared with the medical team. But yeah, we don't want them to go through withdrawal on top of everything that's going on. So thank you. And Wanda says not eating for the woman with the question, is that eating or not eating? And not eating, and you are correct with that man, I'm sorry. Do we stay on if they are in the hospital and or nursing home? Yes. Follow your patients. They will feel great comfort with you. Let's say they have to go into the hospital for whatever reason, boy, when you come through that hospital door with your shiny face, they feel great. So yes, and then you're on top of what's happening with them as well. So I follow them all over until the end. So if they are being put in a nursing home and that's still the agreement with the family and the patient that they want that doula there, absolutely, it makes for a beautiful continuity. Can hospice be considered support, thus allowing patient to stay at home? Can hospice be considered support? No. Natasha, for the live alone, no. And you know why? This is exactly why we have doulas. Because as a hospice nurse, many times I was only there for 1 hour once a week if my patients were stable, and really only an hour a visit, even if I went 3 times a week for 1 hour. So hospice can't assume that responsibility for that patient. You know, hospice was made originally with what's called a hospice house. And so they were houses where people would go to have their end of life in a community environment and be cared for there. And I have a dream of bringing that concept back. I have a dream of, it's so needed. We have so many people that don't have children or family. We have so many people that just the family's not able to care for them. That if we could have hospice houses where they could go, then it would be so incredible. So unfortunately, unless it is a hospice wing or a hospice home, which there's very few of, it's not an option. Sorry to say that. How does the Roxanol work? Does it cause the patient to sleep and therefore the breathing is easier? Carol, the morphine works by having the airways of the areola of the lungs open up as much as possible, allowing the most air to get in so it eases the breathing in and out. The small, and again, I'm talking about a very small amount, does that without really causing sleepiness for the patient. But there are higher doses of morphine that are needed in some circumstances, or as patients advance, that could cause some sleepiness for them, but that's not the reason for the air to be better exchanged. This is really due to the effect that it has on the airways, allowing them to open up as much as possible for the most air exchange. Good questions. Okay, does anyone else have any questions on that? I know that this might be, and I know that level 2 can get a lot heavier in its content, so do not worry. This is really empowering, exciting information that you're not going to get all in one sitting. And that's fine. We're going to go over it again. You can go over this webinar again. You can ask any questions in the Facebook group. That's what it's there for. I want you to really think about it. And remember, you're not supposed to have to memorize all of the things that we're going to be going over in level 2. I want you to know that they're there for you to revert back to. If you have a patient, again, with liver cancer, ALS, whatever it will be, you go back and you can pull the symptoms and interventions right from your classroom at any time. Would you please repeat the reason why you wouldn't give morphine and Ativan at the same time? Thank you. So Wanda, when I say the same time, I mean the same time. So I would not give 2 pills at once of those medications or 2 liquids at once, because I wouldn't know which one is doing what. So let's say you have a patient and they're a bit anxious, but now they're having some breathing trouble. And I said, well, okay, so I'm just going to give a small dose of morphine and a small dose of Ativan and knock them both those issues out. I can't evaluate the effectiveness of what medication did what, because morphine can come. Okay, so let's pose it this way. Your patient's anxious because they can't breathe. So you give a dose of morphine, they can breathe better, their anxiety went away. Okay, so then I'm like, oh, okay, great. So now I know that her anxiety was really directly related to her not being able to get some breath in, and that morphine took care of that. So I'm going to be having all this information for the next time it comes up. However, let's say we have the patient, she has anxiety, she has breathing issues, they had getting worse, had like a semi going to a crisis, had a dose of morphine, then the caregiver, it wasn't 100% back to normal, gave her another dose of morphine, and her breathing seemed to be better, but she was anxious, and because she is just, on edge, and people that have that anxiety, it's sometimes very hard to bring back down. Well, now we know, okay, the morphine helped with the breathing, but this woman really has anxiety issues. So let's wait, 30 minutes and give that dose of Ativan. That's a healthy amount of time. And let's evaluate what that did. So now you had the caregiver give a dose of Ativan, and wow, things got so much better. So that patient is breathing fine, but also her anxiety is down. So you can really start to evaluate again the effectiveness of what you're using and how you're using it, because that is critically important for your nurse to know, and especially when things are going to continually decline in presentation, you might need, and you often do, more medications. You want to know that you're being able to count on the reaction of what one medication did, so that a higher dose of that would probably be the effect that you're looking for. So I just, rule of thumb, just never give them on top of each other, because you can't evaluate what's working. Okay, I hope that makes sense. Thanks, I understand better now. Okay, great. What's the Facebook group name? Okay, Natasha, so you should have been invited with several emails, one with your welcome email to the group, to the class, and the other, I think, was attached to the replay that is sent out and posted in the Facebook group. But obviously, if you're not in the Facebook group, you can't get the replay there. So what I would say is that it is the spring 2019 Doula Givers Institute Spring 2019 students. But what I'm going to do is also have that link sent out again with the replay of this in an email. And if you still are having trouble finding the Facebook group, please just email support@doulagivers.com and we will send you that direct link. But it is Doula Givers Spring 2019 semester group, and it's a great group. We have breathing and anxiety at the same time. Do we give morphine or Ativan first? What would you think? What is the premier symptom and that your patients with emphysema and COPD, what is their biggest complaint that they usually will share? Breathing. What is the best friend for breathing issues what is the best medication for breathing issues? Morphine. So morphine always first, because within minutes that's going to help the breathing. We cannot play with breathing issues. We want to make sure there's tight symptom management, that morphine is your best friend at end of life. And with these breathing issues, the Ativan is a nice cousin, and it can help if you need it a little later on. It's always the morphine is going to be the main one, and you want to make sure your caregiver and families are completely comfortable with how that's administered, what dosaging, when it's needed, and what the plan is. So we'll be revisiting this during the medications. We'll revisit during our case studies, which in level 2 that we're going to do a lot. We're going to have a lot of patients and a lot of families, and we're going to have, usually there's going to be morphine that's involved at the end for either pain or breathing, but we'll go over that some more. But just know, again, if there was one medication that I only was able to have one medication to use with my end-of-life patients, it would be morphine, bar none, because it's the best medication for breathing in low dosages, and it's great with pain. So it really works really, really well. Okay, so give 2 doses before trying Ativan or after 1 dose if first dose doesn't work. So Natasha, this is really, again, going to be taught by the hospice nurse, and it really depends on what you're seeing. But I will tell you the rule of thumb. Okay, so let's just take that case that we had, where we had the end-stage emphysema, we have end-stage COPD, and we have the anxiety, and we have breathing issues. So the drill, let's just say we're going into that spasm. The rule of thumb, usually how it's written down in the orders for the medication from hospice, is usually it will be give a dose, a 5 milligram dose of morphine to the patient within 5 to 10 minutes. If that patient is not back to the baseline, give another dose of 5 milligrams Okay, so that's within that 15-minute period. Then from there, you can think and see if you need Ativan. But it's always going to be one dose of morphine. Are they back to square one, or just did it help just a little? If it helped just a little and mom is still breathing really challenging, she gets another. Remember, these are low doses in milligrams. And usually that will calm it down. I would wait then. I wouldn't even enter Ativan into this picture, because this usually will suffice and handle it really well. The Ativan and the morphine have synergistic effects, so it's a lot on the body. It can be a lot, so that you don't want somebody to get knocked out. You want to make sure that you're spacing that apart, that Ativan introduction, only if you need it. And the morphine, usually the 2 doses usually help and do everything. So again, see what the orders are and make sure your family knows it, but it's usually the 2 doses of morphine. And if you, again, gave me one thing, it would be morphine, because I can do wonders with it. Thanks for rule of thumb. Got it. Okay, great. And are there good medications available to ease breathing for patients who are allergic to morphine? There are medications that they use in lieu of morphine. They're a lot more expensive, so they use them, and they use them sparingly. And they are in that category of the opioids, so they will help with the breathing. But morphine has been the most effective. Now, opioids in general, narcotics in general, you've heard of respiratory depression, can cause respiratory depression. So they ease out the breathing and they lower, the amount of breaths that people take. So all of them in all those categories will be helpful. But again, you probably have to just see from your hospice if somebody was allergic, and this is obviously something that they will be on top of right away. Make sure that it's available in a sublingual form that the person doesn't have to be able to swallow. So Dilaudid is another one that people will usually get when they're allergic to morphine. Dilaudid, it's very expensive, so they don't really like to give that out too much. But yes, there are things that you can use that hospice will order. And that's the other thing, that you'll know right away on your intake form what allergies, if any, that your patient has. But this is, again, not your responsibility. This is all done by medical managers, but they are strapped and they are running with a bunch of patients. So it's always good to have a second pair of eyes. It's always good to be double checking. I have 2 elderly friends allergic to opioids. Yikes. Okay, well, that's okay. It's okay. I mean, it depends on what they present with, as they get to their end of life. And what I would say to you is make sure that their care provider, their doctor, their hospice is upfront knowing this. So they might, and not everyone, ends up on hospice and things, but they might not even have issues with pain or breathing, but gosh, I want to be ready if they do. And so you want to make sure that, because again, now you even put another layer of, getting a medication that's not common, more expensive. So you really want to always be on the early side of setting things up if you need them. So it's going to be okay. It's going to be okay. But there is diligence that we have to be with making sure our medical providers know that they are allergic and what's the backup. Do doulas document care in the patient record? No, Janice, you don't. You have your own documentation that you do, that you keep for your care plan, but you're not doing anything with hospice care plan unless hospice is going to ask you to do it. So there's been a couple of hospices that have hired doulas to be on their team. Then, of course, you will have your care plan based on them, but most doulas are independent practitioners working alongside of hospice in this care of that patient. And so you have your own documentation. You will share information with hospice team. They will share information with you, but you don't have to document in their chart unless you work for them. All right, everyone. Thank you so much for being part of this class, and congratulations on getting to level 2. It's really exciting what you're going to learn now, and you can see that it's being layered. Now you're getting more specific in the nuances of disease processes and how to help patients at the end of life. And the pearls that you're going to learn are going to be absolutely incredible. Clarification: the doula is never administering the medication. Is it the family member? What if a doula is present? Will the family expect you to administer it? What if the family gets nervous and freezes up even though you have practices with them? Do you just guide them? Okay, so let's take one question at a time. The doula never administers medication because this is keeping you safe in the laws that are presently available. That we have to keep this really, really clear. So I am going to teach you that you never, ever, ever give a medication, not even an over-the-counter medication, to a patient. Yes, it's the family member that's supposed to be giving the medication. What if the doula is present? Will the family expect you to administer it? No, this has been very clear on your interview. When we get to level 3, we'll talk all about your practice and your interview with the family and the patient and sharing what you do and what you don't do. That will be crystal clear in that talk, that you do not, they will sign a agreement to that effect. So no one will expect you that you're going to be giving a medication. What if the family gets nervous and freezes up even though you've practiced? Get that hospice nurse on the phone. You can have a hospice nurse. There's 24-hour hospice nurses that are on call. You can have them on the phone and they will even make a visit to your house. But usually, and that's why at the beginning when I said there's a colored dot on the packet, is because of just this thing. When the family is freezing up and scared, they get that hospice nurse on the phone. The hospice nurse says, go get the packet with the purple dot or whatever it is that they want you to use, and they walk you through it on the phone, calming it down. You will remind them just remember what the hospice nurse told you. If you find that they are completely frozen, they can't do it, they get the hospice nurse on the phone and the two of you will guide them through. I would say that if you're facing a time where you have a patient who's requiring medication on a regular basis, that it's getting a bit tough, that you need to have somebody in that home that is comfortable with that medicine, that knows what's going on, so that you're not scrambling and hitting the wall at places like this. But some things can come out of left field. As much as we were prepared, sometimes, you can't help but somebody panics. Remind them to take a deep breath, that this is okay, that they've done this before, that they've got this, because they've been taught. But also use whatever you can, and even get that hospice nurse out there to the house. The on-call nurse is there for that reason. Use them. What if you're alone with the patient who goes into spasms? You shouldn't be alone with a patient who's in a high level of being able to go into a spasm. You just shouldn't be in that predicament, because you cannot give the medication. So you shouldn't be there alone, because that's a really high probability at the get-go. So again, you're setting this up for you'd have somebody there in the family with you. They don't have to sit at the bedside. You're with the patient. They can just be in the house, that if you need it, they will give the medication. Prevention, prevention, prevention. And we can anticipate these things can be set up ahead of time. Can an RN doulas legally administer meds? Yes, RN doulas who are going to wear their RN hat and have that as part of their practice, that puts them in a whole different place of legality, of insurance, of what they need to do, of liability. So it's going to be up to them. They can, if that's what the hat they want to wear. I personally would stay away from it. That's me personally at this time. I just would. There's just no reason that you'd have to. Is late stage COPD, in late stage COPD, are you always in a stabilization mode because of the breathing difficulties? In late stage COPD, are you always in a stabilization mode because of the breathing difficulties? I'm not sure if I understand that. I'm sorry. You're not always in a stabilization mode or phase. Could you just rewrite that? I'm so sorry. I'm just not fully understanding what you're trying to say. In late stage COPD, are you always in a stabilization mode because of the breathing difficulties? So stabilization phase, you might not even be in a stabilization phase depending on where the family's at and what's happening. Breathing difficulties are always going to be in mostly in an anxiety um, place. There's always going to be stress and anxiety in that case for the most part in breathing and stage COPD because it creates that much anxiety for everybody. So acute. Oh, let's see. Yes. Okay. So, yeah, I would say that it always is acute. Although, if you have time, if you have enough time with them, and this depends on, again, days, weeks, months. I mean, usually you don't get months. If you can build the trust with them and you can share with them, the care plans, and again, they trust you and what you would do, then you can really get that stress down. So for this family, for one of these cases, that the yeah, that's exactly what we did. We got the stress level down. We built the stress with. I mean, it's a really awful disease process. I'm just sorry, it just really is. But the patient was good. She was fine with it. The two daughters, they were fine with where we are. Bob had a bit of a trouble accepting all this. But as far as those stresses that were and anxiety that was happening, we really got that to a beautiful place where it was down a lot. So it was not an acute issue. It's just, again, a really difficult disease process. I think she means stabilization phase before transition phase. So unfortunately, thank you, Florence, for trying to clarify that. So stabilization, not everybody gets a stabilization phase. So let's just say we went into this case and the anxiety was not able to come down, that the stressors, that everyone was just completely checked out. We wouldn't even have a stabilization phase. So we'd be going right from acute, trying to like lower that stress, get that down, to transition phase. Not ideal, not ideal, but it does happen. Okay, great questions, everybody. I am so impressed with this group. You guys are really asking great questions and you're really on it. Okay, that is what I was getting at. Perfect, Amy. Love it. Okay, so again, congratulations on being in level 2. Really exciting things are happening for you guys. You are asking wonderful questions and I'm really, really proud and impressed. So thanks. We'll have this recording sent back to you within 24 hours. I'm going to again have them put the link to the Facebook private group that you're in for your semester if you're not in there yet. And we will see you in level 2, class number 2. Thanks, everyone. Have a wonderful night.
Welcome back. Thank you, Nadine, for picking up the slack for me. I so appreciate that. Welcome back, everybody. Isn't that good? It makes my heart and I was catching myself putting my hand on my chest, just to, understanding that when people are having difficulty breathing at the end of life, it makes me so grateful for my breath. So just want to say welcome back. Congratulations on completing week 5, level 2 training, module 1. We're going to just go ahead and have you guys raise your hands. There's the digital hand feature down at the bottom. Veronica already has her hands up. And then you can also be sure and do #question in the chat, and I'll try to get to as many questions as possible. So, Veronica, thank you. It's good to see you. Green's a good color for you.
Hello. So the question, the issue that I have is like it went shortness of breath and anxiety, but there were 3 other things that were supposed to be talked about in that section. And because of the glitch in the recording, we didn't get those.
Okay.
And all of a sudden we're talking about medications that and the medications too, we missed medications. I know nothing about this the nausea medicine or the lorazepam. So is there a way to get that straightened out? Where would I go to get that reviewed properly?
Yeah, for sure. So in the recording, in your classroom, there is the recording of this video, so you guys can rewatch the video there. But I'd be
Okay.
happy to go over those medications with you, if you're okay with that. So Suzanne first talked about the Roxanol or the liquid morphine. So this is a highly concentrated medication, and I like to, when I am recommending or advising someone on how to use the medications, the morphine, typically we always start low, low dose, and slow. So typically when the medications are administered, hospice always will start very low and slow. So they'll usually start off with a quarter of a milliliter. So the medications are going to either come in a pre-filled syringe. So that way the family caregivers don't have to draw up the medications. But in some states and in some cities, some hospices do provide a 30 ml vial that the family caregiver will have to draw up themselves. So morphine is a great medication for pain, and it is a wonderful medication for shortness of breath. Those medications are critical to have on hand. There are other medications that can be used, such as Dilaudid, hydromorphone, but unless they have an allergy to morphine, those other medications can be used. But morphine is typically the medication that is used at end of life. The liquid Ativan or the lorazepam, and I want to kind of circle back about the medications. The medications are in liquid form because people are unable to swallow pills at this point. Sometimes as they transition, they are able to swallow pills, but liquid is really the recommended dose because when the hospice nurse or family caregivers are administering the liquid medications, it's actually administered in the cheek pocket. And then the medications will just slowly go down the back of their throat. Even when someone does not have a swallowing reflex, that medication will be effective and it can actually be absorbed into the cheek. Oftentimes it'll just slide down the back of the throat, and someone does not need to swallow those medications for those to be effective. So liquid Ativan or the lorazepam, typical dose of the lorazepam is 2 milligrams per ml, and that is used for anxiety. And it's a great medication, especially for our COPD patients and our emphysema, anyone with any breathing issues when they have shortness of breath, they are going to feel anxious. Suzanne always recommends when giving those medications, you want to create a bit of a gap. I have seen where both medications have been used at the same time, but Suzanne really recommends in order for us to fully see if the medications are helpful, we typically recommend giving one medication, typically the morphine first if it's for shortness of breath or pain. Wait can take a little bit. Sometimes feels like it takes forever, at least 20 to 30 minutes for those medications to be fully effective. And then you can evaluate, is the person still anxious? Are they in pain? Then you can administer the other medications. Lorazepam is a wonderful medication that can be used at end of life for anxiety. So the ABHR, RDT means rapid dissolving tablet. So I've seen it actually used both ways. It's a compound medication. So ABHR stands for A is the Ativan or the lorazepam. B is the Benadryl or diphenhydramine. So Ativan, as we just talked about, is lorazepam that can help with anxiety. B for Benadryl or the diphenhydramine can help it's an antihistamine. And the Haldol is H. The haloperidol is another medication that can really help with anxiety, but mostly it is for nausea. It can help with the agitation. That is a really effective medication for that restlessness or agitation. And then the R is Reglan, which is also an antiemetic or anti-nausea medication. That ABHR rapid dissolving tablet can certainly help with nausea. It's really effective, and the name, the rapid dissolving, that can actually just go in the pocket of the cheek. Sometimes it can be swallowed, but the rapid dissolve can actually just with a little bit of moisture in their mouth, it can dissolve and work very effectively for nausea. So one of these, the rapid dissolving medication actually it actually helps different pathways. There's a medication typically nowadays, or just if someone is getting chemotherapy or having nausea due to their chemotherapy, there's a medication called ondansetron or Zofran that works so amazing. Oftentimes we think we're nauseated and it's our stomach that's causing the nausea, which is true, but these particular medications can actually help three different neural pathways in the brain telling us that we're not nauseated. It's kind of magical. So that's why it takes three different separate medications, the ABHR tablet or cream, that compound covers all of those neural pathways in the brain to help with the nausea. So those are the top three medications that are typical of the comfort kit. In the comfort kit, not always, but sometimes they will include a Tylenol suppository that can be used as comfort. Suzanne had mentioned earlier in the training that the suppositories can be helped when someone has a high fever. It is invasive, and not everybody is open to having use a suppository at the end of life. And so we can do some cooling measures like a cool cloth, or removing a blanket, removing socks from the feet area. So sometimes that can help with fever reducing using the suppositories, but I usually check with family caregivers to see if they would be comfortable with that, as it is an invasive. There's also in your list of medications, and under module 4, there's a whole list of other medications. The compazine is another medication that can be used for nausea that's not as common as the ABHR or the haloperidol. Those are both really incredible medications for nausea. And then the hyoscyamine, that can help with nausea as well. Sometimes people are not nausea with secretions. So that one is something that is sublingual that can help with when someone has an excess of mucus or this secretions that can happen, that can help dry the secretions. But what can happen is that it can make someone excessively dry, and it doesn't really help the secretions that are kind of trapped in the throat. Usually, typically, repositioning that person will be more effective than those medications. So I hope that helps answer your questions, Veronica. Of course, now I've lost you on my screen.
No, I'm right here.
Oh, there you are. Perfect. Did that help answer your question a little bit? Perfect. Yeah. Just want to remind you guys that we are not going to be the expert on the medications. The hospice nurses are going to be the expert on the medications, but really going over the medications in the comfort kit with your family members is so important, because as Suzanne explained in the video, we really want to be prepared and act as a guide for people, because sometimes the medications need to be administered right away. Even though we're not administering the medications, we really want to be that calm nature, and maybe perhaps doing that drill beforehand. I love the idea of the hospice companies putting those colored stickers. I've seen that. It's so effective. And really, their hands are shaking. They're so nervous. And if you're familiar with the medications and have a little bit of knowledge, you being that calm force inside of at their home, just some reassurance can really go a long way. So again, not giving the medications, we're just there to support people. So thank you. That's a great question, Veronica. I appreciate that. Michelle, you are next. Good to see you.
So let's see, Veronica had asked about the other 3 diseases. That there was 5 that she was going to talk about. And we only talked about emphysema and end-stage COPD. I think the next 3, the lung cancer, liver disease, and pancreatic cancer, are in the module 6.
Yes, yes, yes. Thank you. Yep. We just covered the emphysema and the COPD. Anyone with any respiratory end of life conditions were just covered today. So just COPD and emphysema. Thank you, Michelle. Yep. Yep. Perfect. Thank you. All right. And Terry, you are next.
So I just wanted to say that a lot of the patients now, the respiratory patients, COPD, emphysema, they actually go to pulmonary therapy, and they are extremely educated, like before their end stage. So they are extremely educated on their medicines. They know energy conservation. They know pursed lip breathing. They know a lot of the techniques. So they know them before we even get there. I used to teach, I'm an occupational therapist, but also I used to teach pulmonary therapy. So a lot of them, they are so educated on it. So it would be a good idea if you ask them if they've been to pulmonary therapy, because then they will know a lot more than you do. Because they could have been in pulmonary therapy for years, and they go over all the medicines and they go over all the techniques, and if you're going to try to retrain them, they already know everything, if they've had pulmonary therapy, not just the average person. But they did a lot more before COVID. It kind of stopped with COVID because it was group training, but now they've reinitiated it. So but pulmonary therapy is a great therapy for patients with COP and emphysema.
Excellent. Thank you so much. You're right. We learn so much from our patients because they have been doing this for much longer than we have, and really being able to support them. And just yeah, I've learned so much from my own patients. So thank you, thank you, thank you. Yeah, they are the experts. And really trusting what they say, Terry, that just brings up a really good point of just really trusting what they're saying. And if they, I think one of the great reminders that I have is I have a tendency to ask like multiple questions at once. And so, especially with my pulmonary patients, it's really just slowing down and just allowing them to say, ask those yes or no questions, and really allowing them to conserve as much energy as possible. So, yeah, great, Terry. Thank you. Thank you for all the work that you've done in that field. Excellent. I'm
Oh,
so glad that you're here.
I really enjoyed it. Just getting a little bit harder at my age. It's hard to lift the 500-pound patients.
Yeah, yeah. I'm so glad you're here. Thank you.
Thank
Thank
you.
you. You're welcome. Okay, Veronica, I see your hand up again.
Yeah, because Antonia put it in the chat that the screen that got cut off was the symptoms screen, not the disease screen. So it went shortness of breath and then anxiety, and then there were three other symptoms of the disease that we missed. Can you
Okay.
find that one, please?
Yep, for sure. For sure. Let me go to the slides here just to make sure. Let me go to the slides.
It's way in the beginning. Oh, maybe not. Well, it's after the medications. It's
Okay.
after the medications.
Yeah, shortness of breath, anxiety,
Right.
increased respiration rate, and increased heart rate, and shaking and trembling are symptoms that you will see with the COPD emphysema patients. So shortness of
Okay.
breath,
Increased respiratory rate. Then what else? Increased heart
increased
rate.
heart rate, hmm
Uh-huh.
and then shaking and trembling.
I'm shaking.
So we do
Do
have
we
to be
know why
mindful.
the
Oh, go ahead.
do we know why the shaking and tremors?
I was just gonna speak to that. Um, So it could be multiple of reasons, but sometimes when they take their medications, Suzanne had alluded to in one of the case studies about a woman who had multiple inhalers at her bedside, and she may even have a nebulizer at her bedside. And so when you're using those medications, especially albuterol, can make someone feel super jittery and shaky. And so that might cause the tremors and the shaking. But really, when someone is not getting enough oxygen, then really they can have shaking. And then also when someone has COPD, they're not blowing off enough carbon dioxide, and so that can really cause shaking. It can cause a little bit. It can cause confusion. It can cause weakness. It can cause shortness of breath. So when normally we inhale and we exhale, and those are pretty even breaths that we're taking. But with COPD emphysema patients, they're really breathing, and maybe even Terry could speak to more about this, is they're really just breathing from the top third of their lung capacity. They are not breathing from their full lung capacity. And so they can have carbon dioxide retention, which can cause that shakiness, confusion, dizziness, really fatigue. They get super tired. Their breathing just becomes labored, and they're just so fatigued. It takes a lot of work just to be. Yeah, hopefully that was helpful.
Thank you.
Thank you. You're welcome. Susan, you are next.
Okay, okay, can you hear me?
Yes, yes, welcome.
I just wanted to comment that I've been going into the Doula Givers Main Institute website, and I watch and these actually before we even do it here, along as download everything, because you have to learn for me, I like to see things many times, so that's always a great resource. I'm sure people are using that, but just in case others weren't aware of that, you don't have to, you don't have to always go back to the live. You can go what it was if you weren't in a live class. And then I was also going to comment on, really what we're doing then with the education, even if the patient or the loved one has been through pulmonary therapy, as mentioned, we're really teaching the family, because they haven't, their mom may talk about it or whoever, but the patient can't speak to that so much, but they understand. At least for us, we know that they're educated if they've been through that. But we're really just doing these drills and teaching the family. Is that correct? Is that the way? That's the way I'm at. Yeah.
Excellent. Yeah, excellent point. Yeah, and like what Tina was alluding to, those patients, especially at the end of life with any respiratory chronic illnesses, are the experts, and it's really the family that's going to be doing the caregiving and the administering of the medications. And we need to help lower the energy in that home, especially because when someone is struggling to get that breath, it can be very anxiety provoking, not only for our client, but also their family members and their loved ones. So, whatever we can do to support them. Yeah, excellent point, Susan. Yeah, thank you. And to your point too about the classroom, I really want to encourage to remind everyone, as we're going through these courses, there's extra information there's the workbook. Of course, if you have downloaded that, you're welcome to download and print that out if you'd like. But there's extra additional handouts, case studies that are part of the workbook in the level 2 week 1 end of life doula training. There's a manual, so be sure and look at that, because it goes over more of the medications that we talked about. So there's lots of additional resources in your classroom. And just as a love note mention, please be sure and mark it as complete, because as you go through each module, there'll be page 1, 2, 3, sometimes 4, and you'll need to click mark complete so that you can see your progression as you continue along in the course. And then that'll just really help you at the end when you go to get your certification. You'll have all of those modules completed. So thank you, Susan, for all of that. Yeah, appreciate it. I know we're running over. I just wanted to answer a couple more questions. Michelle, good to see you.
It wasn't really a question as much as when they have the slide on the thing, I've been snipping it. If you have not a Mac, a regular computer, you hit Shift and the little window button, hold those together and hit the S. It puts up a little cross, and you can snip the whole frame, clip it, and throw it in some notes. So you don't have to what was that last one? I missed it because she went to the next one. Anyway, that's what I've been doing, taking notes.
Excellent.
There's a little snip
Excellent.
that.
Love it. I love all the tips we can get, right, Michelle? Thank you so much. Yep. Yeah, I'm always doing screenshots and stuff because it's a lot to take in and it is a lot to remember. So it's always good to have those extra tips and tools. Thank you, Michelle. I appreciate that so much. And then there's another Michelle. Hello, Michelle.
So I have a client who is on hospice, and they gave her 3 to 6 months. She is now going into her 4th month. But when hospice came in, they gave her the liquid morphine, and the first time they gave it to her, and it makes sense how the blocking of the airway, like the carbon dioxide can't get out. But when they gave her the morphine, she actually thought she might be allergic to it because she would shake and she would uh, get really high anxiety and very dizzy. Is that a normal reaction to the morph? That can't be normal.
Yeah,
And she has heart disease. So her heart is only like working at, well, the last time she was in the doctor in January was 30%.
yeah, that is so hard. So she could be having an allergic reaction. I can't say for sure, but
She
again,
totally refuses the morphine. She will not take it because of the way it makes her feel.
yeah, and that's understandable. So hospice should have other medications available for shortness of breath. Dilaudid or hydromorphone is another option that can be used for shortness of breath. Morphine is a great medication, but it's not the only option. And so, what the term that they use in hospice is narcotic naive. And so, if someone has not really used narcotics in the past and has not taken a lot of pain medications, then we would classify them as narcotic naive. And so if they started out as at a higher dose of those medications, she may have really not been able to tolerate it because it was a higher dose than her body was used to. And so again, I always just like to stress low and slow. So the 20 milligrams of the morphine per ml is actually quite a lot. And so when we put into perspective of pain medication, so typically Norco or Vicodin, Norco is kind of the most common. Vicodin is the name that they used a long time ago, but the Norcos
This would be
come
for
in
her.
different strips.
This would be for her breathing.
Yeah. So the Norco tablets are 5 milligrams, 7.5, or 10 milligram tablets. And so when people use morphine, which is the same family as a Norco or the hydrocodone pills, it's a 5 milligram tablet. So when you're drawing up the syringe of morphine, it's 20 milligrams per ml. So if you have a whole syringe, a 1 ml syringe, that's 20 milligrams. And so typically when they start a person off on morphine on hospice, they use a 0.25, which is a quarter of the syringe, which is actually just equal to one of those small Vicodin pills. And so if she is narcotic naive, then and they gave her maybe a whole syringe or maybe a half of a syringe, 0.5, then that would make someone typically feel shaky or, anxious or something like that. That may occur. So hydromorphone and Dilaudid or hydromorphone slash Dilaudid are other options that she can take. Unfortunately, there's other medications. Fentanyl patches can be used, but those take a while for the effectiveness. There's also there's other types of medications that can be used. So unfortunately, morphine is not the only option, but it is helpful. I almost wonder if maybe if they just half the dose, maybe she might be able to tolerate it a little better if it was just given at a half a dose. When I was working as a hospice nurse, I would just do If someone was really narcotic naive and they were afraid of taking medications, the hospice nurse would say, let's just give her a quarter. And I would just say, just give her a half of a half. Just start out slow so that they can see how it feels. And the other unfortunate thing that can happen with narcotics when someone does take pain medications is constipation. So people, especially the elderly, they're concerned about getting constipated and addicted to these, which is not going to be the case for someone at the end of life. So hopefully that answered your question, Michelle. Thank you for that.
Yeah, that's perfect. Yep. Thank you.
You're welcome. I'm sorry to go over, is it Letitia? Perfect.
The other thing I would add to everything that you said, Christine, is that if they're not giving it slow enough, they are going to have that reaction because your mucous membranes absorb these medications quickly. So the other thing is to just give a tiny bit, then count to 10 or 15, then give just a little bit more and use the lowest dose that you could find that's effective for them.
Perfect. Perfect. That's excellent. Yeah, thank you so much for that. Oh my gosh, we could talk on and on. I see there are so many questions in the chat, and I promise I will answer those questions and get them posted in the group. Again, we are not giving the medications. This is just general information about how we can support our client and their loved ones on those medications. But really, I want to encourage you guys to take some time and do your homework. You know, I was looking through it earlier, and really there's roles about how you can support the children in the home, right? So if there's a 15, a 9-year-old, and a 5-year-old, those jobs in that drill will be different for everybody, and really just encouraging them to just love on their person. So really take some time to also just take some time to work on your homework. Please be sure and drop in and say hi in the office hours on Friday. That is, let me just make sure I have the time. I'm on Mountain Standard Time. So office hours are Friday from 11 to 12 Eastern time, and then happy hour. So we'll have everybody get together and just get to know one another. It was super fun on Friday. And then Erica, also tech support on Tuesdays 2 to 3. She's also there to answer any questions that you guys might have. And okay, let's do some hearts and then I'll let you guys go. Thank you. It was so fun, you guys. Thank you so much. And thanks for all of your patience with me. When we were having tech issues, I'm getting my internet worked on at my house. So I am going to, okay. So if you could, on the React button, down below, there's send with effect. If you can, yep. So if you can just do the regular heart, I'm just going to pop it up there. It seems to take a picture better when we do that. So perfect. So if you can, on the count of 3, so if you can do the heart without the effect, so just the heart would be perfect. So on the count of 3, I'm going to, and then thank you for the person, and I can't remember who said to copy or do the snipping of the picture screenshot. So I'm going to do Shift Command 3, and on the count of 3, I want everyone to put up their hearts. I appreciate you guys so much. Okay, on the count of 3, 1, 2, 3. Oh, we did it! Thank you! Yay! Okay, I'm gonna go. You guys look so beautiful. Oh my gosh. Okay, I'm gonna go to the next screen. I'll be right back. All right, all right. Okay, you guys, here we go on screen 2 on the count of 3. Ready? 1, 2, 3. Say cheese. Excellent. Thanks, guys. Okay, last one. All right, one more time. Okay, last one. 1, put your hearts up. 1, 2, 3. Got it. Oh my gosh, thank you guys so much. Congratulations, congratulations, you did it. You just finished module, module 5, level 2. You are on your way to be full-fledged doula givers. I am so honored. These were amazing questions. I love supporting you guys. Let's meet each other in the Facebook group, and I want to celebrate your wins, and I'm just over here cheering you on. Sending you guys some love from Boise. Have a great night. Okay. Thanks so much, you guys. Bye-bye.